All right, guys, it's 10 o'clock. I think it looks like we have quite a crowd on, so I think we should just go ahead and get started. And Tracy Jones, are you on if you want to call the meeting to order and make sure that we have a quorum?
I have to take myself off of mute for that to work. Welcome, everybody. Wanted to just quickly make sure that we have our committee chairs on here. Registry, Kelly Vaughn, if you'll just say that you're here.
Kelly's actually teaching a course right now, but she's going to be stepping in soon. And this is Mary Beth. I'm here.
Okay. Thank you, Mary Beth. Crystal for injury prevention.
Here.
Peds.
Yeah,
Kelly Broker. Okay. PI, I believe.
We don't do interviews.
Somebody needs to mute, please. John is in a focus review right now. And I think Pam's going to kind of step in for him. And any other registry, injury prevention, PEDS, PI, education? Jessica? Okay. And then Jesse and myself. I think that's a quorum.
Yes, and thank you, quorum. I called it a forum today for some reason, so thank you. This is going to be a great forum to have our quorum. Also, I guess we can confirm if Karen Hill's on the call. I know she has transitioned jobs at Children's Healthcare, so I'm not 100% certain that this is still really relevant to her job, but she is still our past chair for this group. So is Karen Hill on the call?
Yes, I'm on the call.
Awesome, Karen. So it is still relevant.
Hi, everybody.
Welcome,
right.
Karen.
All right, Tracy, do you feel good about it? We're ready to go?
I feel good.
All right.
Don't make me sing. That'll make everybody cry.
Hey. It is early and we might need somebody to get us, pepped up here. All right. Well, I think we'll take some time this is always hard to do in a virtual forum, appropriate use. But I would like to ask anyone who's not been on this call before, if you will just unmute quickly and introduce yourself and where you are representing and your role.
My name is Nicole Sunholm. I'm from Advent Health Redmond, and my title is Trauma Manager.
Welcome.
Hi, this is Dawn Truitt. I'm from Atrium Health Floyd Polk Medical Center, and I am going to be coming on as the trauma coordinator in the next few months. I'm currently the quality and accreditation coordinator.
Awesome. Welcome. Anybody else on the call?
Good morning. This is Steve Elmgren. I'm the Grady EMS liaison, as well as the communications manager for the ECC and MTC.
Anyone else?
Good morning. My name is Samantha Buchanan. I am with Grady Health System, and I am one of the new trauma quality RN specialists.
Awesome. Welcome to the group.
And may I say, I'm impressed because you were a super nurse. I've read that job description, and more power to you.
Thank you.
Everyone on this call is always recruiting too, so. Also, I have a couple of folks here with me in our conference room who are new to the group. Well, Lee, I think, is not new to the group, but Morgan, do you want to?
I'm Morgan Krause. I'm the second trauma research coordinator here at NGHS in GMC.
All right. Anyone else new on this call? Well, thank you guys for entertaining us all and doing that. I know it's difficult to unmute and speak over each other, but I do think it's important, especially since we're not able to be in person as frequently. So it's very important that we at least hear your voice and kind of know, you know, who's new where. So thanks and welcome to everyone. And so with that, again, for those I have not met, I'm Jessie Gibson. I'm the trauma program director at Northeast Georgia Medical Center in Gainesville. And I've had the privilege of being the chair of this group for a little while, nearing the end of that term. So I'm bittersweet, but hopefully we'll have another couple of good meetings before we pass the torch to Tracy. So let's just go ahead and jump into our agenda. I guess first we do need to approve our minutes, which were sent out via email to everyone with the agenda. So does anyone want to make a motion to approve the minutes?
Jessica Manson, I motion to approve the minutes as presented.
All right, do we have a second?
This is Rayma, second.
Any discussion? All right, I think we can consider that marked off our list, and we can jump right into our standing reports with Georgia Trauma Commission update. And I know that Liz is not with us today, so she had texted me. I think Katie is going to provide this update.
Yes. Good morning, everybody. Thanks for joining. A couple of different things today to discuss. We had our orientation calls yesterday, and I think those went really well. There was a lot of information given out about the FY 2024 changes. One being going to semi-annual instead of the quarterly payments, and also that your FY 23 performance-based scorecard results will affect your FY 24 performance-based payout. And then also she wanted me to go over the slides that we presented at St. Simon's last week or 2 weeks ago. So I'm going to go over those because she wants to have a recommendation that comes from you guys in regards to the FY 24 performance-based pay. So we feel it's super important to have your input and what you guys feel should be rated on those performance-based scorecards. We can come up with stuff all day long, but we're not in the field on a daily basis. So we feel like you guys are the ones that can help drive those decisions. So she did ask that we have a recommendation for the FY 24 performance-based criteria by October 14th. Oh, it's not gonna let me share my screen with, oh, there we go. All right. You guys see my screen all right?
Yeah.
Ma'am.
All right, sounds good. So these slides represent the FY 22 in comparison to what will be at risk for FY 23. So for level 1s, level 2s, they're 80% and 5% per criteria. In 2 areas, there's 10%. That's your timely submissions and your registry full-time position. Level 3 is at 60%, level 4 is at 19%, and burn at 45%. For your at-risk dollars for FY 23, since you will be getting all the money up front, as we discussed with the Trauma Trust Fund, instead of getting amended dollars and having an amended contract, you're getting everything up front. So therefore, more is at risk for FY 23. This is the dollar amount per center at risk for FY 23. And this shows each of the areas based on the scorecard that you guys are familiar with. And for the FY 22 results, we had, these are the areas. For the FY22, you will see the meeting attendance. There was
Got download Zoom.
Guys, please remember to mute your line if you're not speaking.
all right. So for the GCTE meetings, we had 1 center out of 8 that did not meet for level 2. And then the most at-risk dollars were in the peer review committee. 2 out of the 8 did not meet those. And then the response times for level 2, 1 center out of 8 did not meet those. Level 3, we had 1 center out of 5 not meeting response times. And then the meeting attendance for the summer meeting in level 4s. And I think looking at these slides will help you guys in the decision making for the recommendations for FY24. So if you have any questions, please reach out to me at any time.
And Katie, just to clarify, when a center doesn't meet that criteria, then they forfeit that money, and then that money goes back into the treasury, or is it redistributed?
It is actually redistributed to the centers that met all criteria. So it still goes to the trauma centers. It is removed from that center.
Okay. And will you make these slides available to us later? Because some of the people, I don't think, especially maybe some of the registrars, haven't seen this information as much. And yes. I can review it with them so, you know, they understand it a little bit better. I know you've got time constraints right now.
Hey, Katie, I can send it out when I send the follow-up email after.
Okay, great. And the next slide I feel like is the most helpful because this shows that FY22 at-risk dollars compared to what it's going to be in FY23. And so
for
you will see
FY22 just ended in June.
FY22 just, yes.
And then we're in FY23. The state calendar goes from July 23, well, 22 ends in June of 23. So that's what the 23 means. So
yes, so the fiscal year, yes, that's fiscal year 22, which just ended. And so your at-risk dollars significantly increase due to getting all the funds up front. So this year is going to look a lot different with how he received the funds and how much funds are at risk. I think these are super important, and you know, moving into FY24, when we're looking at performance-based pay criteria, take this into consideration. Okay. So this is each of the areas. This is all center criteria. And then it moves into the system participation, which a new PVP criteria for 2023 for level 3s and 4s, or for level 4s, is the participation in rural level 3, level 4 work groups. Or it's new for level 3s, I'm sorry. Surgeon response, or the ACS optimal resource document criteria. So this is based on these items that are on the PVP scorecard. And new for level 3s and 4s is the March pause for FY23, participation in March pause. New for FY23, for level 3s is timely email submission of facility specific TQuIP performance matrix and drill down exercises for spring and summer meetings. And for level 4, the report for the trauma transfer patients to GCTE collaborative is new for FY23. And these are items that are on your scorecard but have no at-risk dollars. And this is for the burn center criteria, nothing new for FY 2023. So to summarize for FY23, there is an increase at-risk dollars due to the increased readiness allocation. The new budget processes for FY23 and into FY24 due to the Trauma Trust Fund, as well as the performance-based scorecard results being based on your prior year scorecard results. So FY23 results, so anything for this year will affect your FY24 performance-based payout. With this, level 3s and 4s, due to them not receiving as much funding, they are based on a stipend amount, so they are protected. We also want to consider funding formula review and revision given the new budget process with the Georgia Trust Fund. So for me, what do you guys need in regards to the recommendation for the FY24 performance-based pay? With these slides, would that be helpful? How you guys let me know what will be helpful.
Hey, Katie, this is Sarah at Grady. I was curious if you could just remind us all how the trust fund works.
Okay, so with the trust fund, I'll go from how it has worked in the past. What we have received is our state funds, our state general funds at the first of the fiscal year. And then around February, they vote on our amended funds, and we will receive the remaining portion of our funds in February. And then that's why you guys would receive an amended contract with an increased readiness allocation due to that amended budget. For FY23, we are receiving all the funds at the beginning of the year. There may or may not be an amended budget, but it's much less than what we've received in the past. So all the funds that you would get up front versus getting an amended contract at the end of the year. So you're getting all your funds up front. That's why there's such an increase in the readiness allocation.
So you're saying the amended, if we do get amended monies, you know, at like the beginning of next year, it'll be a lot less than what we would have gotten in the past.
Correct, because you're getting all those funds up front.
Right.
Yes,
okay.
Because you're still getting your same amount that you received. We made sure we based the budget on total budget dollars for the FY, so that included your initial funds and your amended funds. So you're just getting all that up front.
And not having to do another contract.
Correct.
Hallelujah.
Yeah, I think it's just helpful that for our own like budgeting purposes and internal, reporting back to our organizations, we know the amount we're going, instead of it being always, up in the air, are we going to get this large lump sum amendment? Now we know the full amount in advance. And so I think that just makes things much, much easier on all of us.
Yes. And it's going to be a transition period for all of us involved. I feel like this year is just a big learning experience when it comes to the budget, but I am here if you guys have any questions, and we can get through this together.
Well, thank you, Katie. I think that was super informative, and I do think that the slides will be very helpful for us. I think from, the real high level, like what my takeaways, I mean, I know fiscal year 22 and 23, we didn't really have much change. And now you guys are trying to shape what the PVP for fiscal year 24 will look like. So I guess one other question I would have, and we may have talked about this in some other forums, but are there any things that you guys are already considering that you might want us to kind of chew on and provide feedback?
So the items that are on the FY23, those are items that we did make many changes to FY23, like the March pause, but that's going to be coming to a close after this fiscal year. So items like that can come off. So either replace them or increase the risk dollars in other areas. But no, there's nothing other than like the ACS verification for FY25. Those items will stay on there, and then they will have at-risk dollars for FY25. Does that make sense?
25 or 24?
25. So that item will stay on there for FY24, but with at no risk dollars, just to keep it at the forefront.
So you guys need input though into the FY24. That's what you're needing by.
That's correct. That's
Okay.
correct. Yes.
I know that I have brought up, and we're going to talk about this a little bit later on the agenda with the GCTE Executive Committee kind of restarting. We had talked about putting something in there about registrar and or PI and other team members to consider. I don't know if we want to tie it as a requirement to attend TQIP and or the state meeting, but we were just trying to look for ways to get those groups back to the ability to network at least like once or twice a year with their colleagues from not only in Georgia, but across the state. So I didn't know if we could consider a little stronger, maybe at risk, like if you can't send one registrar to TQIP, you know, that might cause you to lose funding or something. So I think as everybody's thinking through this, though, that was one of the things we've already kind of talked about as a group, and that'll probably be my recommendation, but just kind of think about that and what might make operational sense and what's actually feasible for us to do all of, you know, if it's just level 1 and 2 and 3, and, you know, I guess it's best if we all give you feedback on what our specific level is rather than really looking at it as a whole. Is that accurate?
Yes. Yes, that's a great idea. By level is definitely more beneficial and more helpful, just to break it out in that way instead of saying everybody across the board, because it's not going to be the same for everybody across the board. So yes, I think by level would be a good way to break this down. Each level collaborate and then come together with a recommendation by level.
All right, so I think unless anybody has any specific questions for you, we can move on. But yes, I think the takeaways, if Katie will share the slides with the entire group, and then do you need the feedback by the 14th, I think, but maybe we can kind of aggregate that so you're not getting 1,000 different emails, Katie.
Okay, that'll be good.
So how about after the meeting, I can actually send her slides out to the entire GCTE. And then if you guys want to funnel the feedback, I just want to try to make it not as complicated for Katie to have to dig through everything. So I don't mind to get them and then work with you and Gabby and whoever and kind of collate the answers, if that works.
Okay, and I also have the document that I send out to you guys with the contracts that has by level performance-based pay criteria. I don't have the slide up. I shared it yesterday in the orientation, but it just has for your level, and then it has the at-risk dollars. So I can send that out because that might be easier to work off of instead of working off these slides that have all the levels together.
Yeah, I think so, but I also like the slides as well because I think it's very concise. So maybe we can just share both. That would probably be best.
Okay, that'll work.
All right. Well, and the good thing is we don't have another meeting, so we'll just do all of this kind of communication via email and get the final GCTE recommendations to you in plenty of time.
Okay, sounds great. Thank you guys for all your help.
Thank you, Katie. Great overview. All right, and I do want to apologize for the next agenda item. I failed to remove David Newton from the party responsible. I know David is not with the Office of EMS and Trauma at this point. So I don't know if Marie or Renee are on the call to provide their update.
Hi, everyone. This is Marie. Yeah,
Hey,
I don't believe Renee is on the call. She is at a site visit today. She said she would join us probably towards the end of the call if they take a break or end early. So yes, I'll give our report today. And you're right, David Newton has moved on to other opportunities, and our new Office of EMS and Trauma Director is Michael Johnson. He was the cardiac care director and moved up to be the systems of care director in the Office of EMS and Trauma. So he was over trauma, EMS, stroke, and EMSC. So now he is over all of the Office of EMS and Trauma. So we welcome him into his new role. He wears many hats, but he has good qualified people to handle things underneath him in the different sections. Again, as I said, Renee's down in Dublin today participating in a site visit, and she'll join us if she can. The orientation session yesterday went well. We had between 18 and 20 people on the call. So between the two sessions, so that was good. For many of you, our presentation was a recap of things you already know, but Katie's and Gina's presentation was really informative. The pilot is still ongoing. So I will be following up with the pilot centers to see if you guys are ready to start the training next week, hopefully, and do the download to the Georgia Patient Registry. And if all goes well with them, then everybody will receive the same file from ESO to do the downloads. The OTCPE and OBCPE forms for fiscal year 2022 have been reviewed. We have one left in the queue, and the fiscal year 2023 form will be revised. So if anyone has any recommendations or for the changes you'd like to see or something that would be more beneficial for you in your center, please let us know. And specifically the burn centers, we really want to help you make that form be beneficial for you. So
just to let everybody know, the OTCPE is the Ongoing Trauma Center Performance Evaluation. Is that what it stands for?
You're right. And
okay, and that
is for burns.
Okay, and it's really kind of like a quarterly update. We enter into an electronic system for the state to know, are we doing what we need to do to meet standards and get our money. Part of that is just ongoing looking at that. And then we also do that with the Georgia Trauma Commission.
Yes, thank you, Tracy. I was taking liberty to thinking everybody already understood that. But yes, we do have a lot of people on the call that aren't familiar with the acronym. And those reports are exactly as you described them. They are designed to help each center track the deliverables of contracts between OMST and the Trauma Commission. It keeps centers on track and monitoring the things that they need to be monitoring, and making sure that their programs are running efficiently. And it also alerts us to patterns, or lets us know if something's not being done. And so then we can reach out to that center and make sure that everybody is on both sides, OMST side and the Trauma Commission side, know that something's fallen off of the trauma program manager's radar, or there's been huge staff changes that will affect either the data collection or the trauma program performance, and meetings being held, etc. So the quarterly report is really valuable to a center's performance, and keeps you on track. So again, if anybody has any recommendations for changes to the trauma form or the burn form, please reach out to us. Renee and I will be updating that form so that we can open up the fiscal year 2023 quarter one form October 1st. And that report will be due October 15th with a 10-day grace period. we want all of the quarterly reports to be submitted by the end of the month. And it makes it easier for us to get the feedback to you quicker. The next thing I want to share is we're continuing to work with Gina and the GQuIP program. We've been looking closely at the time to definitive care analysis, working with Dan Lynn, our trauma epidemiologist. She's given us the details that we need to dig into those cases that are outliers and determine if something could have been done differently or to improve outcomes. And what this is leading us to is establishing a formal PI process at the state level. So we look forward to digging into that data more and really preparing something that will be established in a guideline for reviewing cases at the state level. Let's see what else. Dan Lynn's annual report for the 2020 trauma injury data has been completed. We submitted it to our communications department and they kicked it back. We have to convert it to the new format. So that will take us a little bit of time. But that is on schedule to be available at the November meeting and the November Trauma Commission meeting. For the 2021 report, we will be back on track as soon as we can get the all of the 2021 data from all of the users, and Dan Lynn can begin working on that, and we plan to have that 2021 trauma injury report prepared by next August, and we'll be back on track. COVID and the transition to our new central site is what's causing the delay for the 2021 data being analyzed. Let's see, I think that is all. Any questions for me?
Hey, Marie, this is Sarah. I just have a quick question about the way the report that we submit to you is then pulled into the calculations for our performance-based pay, or is it, because I think at one point there was maybe a change, and I just wondered if you could review that.
Sarah, that's a great question. Thank you for asking. The Trauma Commission has changed their pay-based performance measures. So the items that we are tracking are more for tracking the performance of the program, specifically the record closure, the surgeon arrival time, monitoring the non-surgical admits, and making sure that meetings and education are being held. So our focus is slightly different from the Trauma Commission's focus for your funding. We do report to the Trauma Commission staff the timeliness of the submission of the reports to us, and we have the ability to tell them your record closure rate and the surgeon arrival standard, whether it's being met or not. So does that answer your question, Sarah?
It does. That is super helpful. Thanks, Marie.
You're welcome. All right, if there are no other questions, I'll pass it on to pass it back to Jesse.
All right, thank you, Marie. That was a great report, and thank you for the for all of you guys for the orientation session yesterday. It's always, you always think, or those of us who've been around for a while think we know what's going on, but I always pick up another thing or two each time we talk. So thanks for that. All right, we will move right into the Georgia Trauma Foundation update. Is Cheryl on the line to give her update?
Yes, I'm here.
Take it away, Cheryl.
Thanks, Jesse. I just wanted to share with you all, well, most of you probably know this already, that the Georgia Trauma Commission is putting together a continuing education database for the trauma community here in the state. What this is a, it's really going to be a directory of sorts that's comprehensive. We're putting together something that we want to make sure is a reliable source to be able to identify trauma education providers across the state. And as you can see on the screen, we need to get certain information from folks who are certified to teach courses that are going to be a part of the database. And for the first year of the database, the courses that we are going to include are ATLS, RTTDC, the Hospital Surge Readiness Program, ATCN, TNCC, ENPC, PALS, PAIRS, and then the Cadaver Lab. What we're asking you to do is, if you are certified to either teach, coordinate, or direct these courses, that you complete that data information sheet and get it back to us. This resource is going to be free for you to use, but we do have to get your permission to actually be included. And also, while it is free to use, it will be password protected. So what you will do, and we'll get this information to you as we get closer to going live with the directory, you will have to contact us, and we will provide a password for you to use. Now, I see Carrie looks like has a question.
Yes. Hi, I was just looking at the list of options and I wanted to see if we could include ABLS, which is Advanced Burn Life Support.
Probably, Carrie, in the future we'll be able to do that, but right now for year one, these are the courses that are going to be included. What I'd like you to do, Carrie, if possible, is where you see on the sheet underneath the courses that are part of year one, it has other courses on there. If you could just add that so that we'll know that that's probably one of the ones that we'll look to bring in for year two, then that would be helpful.
Okay, great. Thank you.
Mm-hmm. And some of you may have already completed the sheet. And if you have, that's great. If you have not and you're certified to teach in more than one of these courses, just put it all on one sheet. You only have to fill it out one time and get it back to us. Are there any additional questions? Oh, one other thing. This is scheduled to go live by the end of the year. So we need you to get your information in as quickly as possible. Kendra Holm, and most of you know her, is the project coordinator for this. She is working with the Trauma Foundation. So certainly if you have questions, you can direct them to me or you can direct them to her. But right now, while we're on this call, are there any questions?
Cheryl,
Okay,
I would just, it's Kendra.
Ahead, Kendra. Okay.
I just would ask if anybody on the call is a course coordinator or a director for their site. If you've not already sent this to all of your faculty and ask them to complete it and fill out the information, if you would do that as well, they can either scan the QR code and the information will come directly to me, or they can fill out the form and either email it to me or just, go ahead and I've sent electronic copies to most of you, but if you need any information, I'll put my email address in the chat and hopefully that'll make it easier for you all. But the QR code is probably the easiest, most direct route if you can share that.
Are there any more questions? Thanks, Kendra.
So Kendra, sorry, just to make sure I heard correctly, do you want to share that? I know we've shared it, like you said, to multiple different groups, distribution groups and whatnot, but do we need to send the form again to this group just to make sure to cover our bases one more time as well?
It certainly won't hurt. I know I've sent it to all of the site coordinators for ATLS. I know I've sent it to as many of the course directors for ATCN, TNCC, EMPC that I know of, but there may be people out there that I just still don't know that you're instructors or know that you're faculty. So the more that we can disseminate this, the more useful it will be.
All right, we can do that. And then Gabby was also kind to put the link directly in the chat for this meeting. And if you guys would like us to pull back up the QR code, we can do that as well. But I agree that is the easiest way to go ahead and knock it out.
Thank you all. Thank you so much.
This is Kelly Rooker. I have a question and comment. Is there a fax number on that form? I know personally our center, the form is blocked. We can't fill it out electronically and send it back. So we would need to print it and scan it back or fax it back.
Kelly, if you can scan it back to me at my email address, which is on the form as well, you can do that, or I will find out my email, my fax number, which I don't know off the top of my head, but I'll get that in there for you all.
Thank you.
Thank you.
Thanks, Kendra and Cheryl. Cheryl, did you have any more updates from the Trauma Foundation?
No, not at this time. Thank you, Jesse.
All right, thank you both. Okay, we are moving right into the Georgia Quality Improvement Program, or GQIP, and Gina Solomon.
Hey, sorry, I had to unmute myself. Good morning. I wanted to give everybody an update. The main update will be on the Arbormetrics project, because we have finally kicked off that project. And I am so excited that we have some updates. We have some movement with that. And I'm going to share my screen. Just to go through, this is maybe a little redundant for some, but since we have the bigger group here, I want to make sure that we over communicate. What's going on? So, okay, can you see my screen?
Yep.
Okay, good. All right, so the Arbormetrics update, since we have some significant movement, I wanted to give everybody the timeline that we're working off of. So the complete project launch should be sometime between Q1 and Q2 of 2023. The build for that is about 6 months, and then we've got training for not only myself, but the centers with that. Right now, I have weekly meetings with the project team. We meet actually today, this afternoon, every Thursday, to go over some questions they have with the build. I have submitted them what data we will have available to send them that they'll be able to work with, and some of the metrics that we may want to look at. And I'm going to show you a little bit of information we had from the summer meeting that's going to drive some of that. We are going to have some sessions where I may be pulling in, you may get an email from me asking you to participate, because we don't want it to be just myself and Dr. Todd driving this project. We want to make sure that it meets your needs. So we may have some focus areas where we pull a PI coordinator in, some registrars, a child program manager, to just kind of provide some feedback on things we're thinking about with that. And those are some engagement sessions. So those will be coming. So this is kind of, where we're at right now. So right now we're just kind of in the slow build process with that. The ESO Central site will move much quicker. Both of these projects kicked off on July 1st. We finally got the contracts through, and it is a 90-day build. for that. So we are hoping to be able to accept data around the end of September, 1st of October to the central site. So I've been working with them with our data dictionary. We went through item what we're going to pull over into the central site. And just to reiterate, I know I've said that before, there are going to be no additional fields that are mandated outside of the state fields right now. So we will pull in some data points that may be there if you happen to be completing, but there'll be no validation rules or anything built around that. The validation rules will be the same as your state downloads. Our plan right now is to, when we get the build done, is hopefully to accept calendar year 2021 data into the registry to kind of use it for acclimation and some baseline data validity studies and those kind of things before we get into that. So all of the trauma program managers at the designated centers got an email from me on Monday asking for 2 users from each center, name and email addresses that will be used for the logins to the central site. I did have a really good question from Jamie, because I know in the past when we downloaded to the state central site with ESO, each center kind of had a generic login that you could share, and so whoever was doing that could just utilize that. And they have moved away from that for security reasons, so we cannot create a generic login for each center. So we are asking for 2 specific people with that. Now, once this all gets set up, we will have the ability to add and change users with that. So that's not an issue. I just got that clarified this morning with the ESO team. So don't worry. I know we transition a lot sometimes, or what people's task may shift, and you may need to add or take away somebody, and we will be able to do that. But just to get started, they need an initial list of folks who will be the ones logging on to the central site to download the data. It will also give you an ability to change passwords and things like that from that perspective. And then I wanted to share, as we work with the arborimetrics, and one of the things that we are doing is deciding kind of what do we want to look at? What do we want on our dashboards initially? And our initial thoughts is we want to start with something that's important to us, and then something that's familiar that we can work with. So we actually, at the summer meeting a couple of weeks ago, posed the questions to the group to kind of say, what did we think our priorities were looking at data? And I wanted to share those because I thought they were interesting, and this will kind of help drive as we build the initial things we look at. Oh, before I get there, we do have a new research fellow that started. Dr. Malaver is our new GQuit research resident. I'm excited to have him. He's going to do amazing things. He has already hit the ground running with our TBI data analysis with that. And Jesse Codner has gone back to his rotation, but he will still be participating with us. So one of the questions we are, or what process measures should we assess with arborimetrics? And so we threw some that are kind of, seem to be high up on the radar. And this was the polling results for that. So I think the VTE prophylaxis will be kind of top on the radar as we start. And I agree that that's kind of an easy one, right? We know what that kind of looks like, and we can sink our teeth into it, learn how to use it. How will that help us drive what we're doing for that? And then ratios in massive transfusion protocol, and then some other things. Now we may have to look at this and decide, we'll par it down. We're not going to look at all 7 of these to begin with. It will be a much smaller batch from that. And then when we talked about outcome measures, we'll look at mortality, and we will have the ability to stratify that by age groups, which will be really important because that'll give our peds population some important information. And then from our meeting and our TQuick collaborative report, we've got some opportunities with the geriatric population on our radar. And that was another thing that the group pointed out that we needed to look at. So we'll definitely be stratifying mortalities by that 65 and up each group. And then here are some other things, that came out in the wash when we looked at it. So we are excited to be in the middle of this project. Also from the summer meeting, we'll be posting the presentation PowerPoints. If anybody wants to go look at them or share them with other members of your team from that standpoint. And then we are working on winter meeting planning, which will be February 27th, 28th, and March 1st. 27th will be a reception. 28th will be the full day of in-person meeting, and then March 1st will be the commission meeting, and it will be at Chateau Alon this year. Unfortunately, Barnsley was no longer an option for us. We love that, but we will be meeting at Chateau Alon, and we're working on some logistics of what other meetings and groups can we have meet during that time. So, and Gabby has done a tremendous amount of work around that. So one thing I want to add to Katie's review, she said we had the orientation yesterday, and Katie went over the performance-based payment, but I do want to point out one new thing in the contracts is there are line items that designated centers to receive any funding from the commission within their contract, means it applies to all funding. They must submit data to the GQuick central site for that. The other line item that is in there is maintaining the ESO registry at this time for each center to receive any funding. And the background behind that is it would cost additional funds to be able to build the platform in a way that would accept data from other registries. So at this time, we do not have the funds to be able to augment that. And right now, everybody, all the designated centers are on ESO. So we just want to make sure that at least for the next 3 years, that's where we stay as we kick off this project. So I am happy to entertain any questions here, or you can feel free to email me.
Thank you, Gina. That's a very good report, and seems that this is actually going to come to fruition after all this time talking about it. So
I know it feels like a lot of time talking, but now it's moving, and it's moving fairly quickly. So that's very exciting.
Certainly is. All right, does anyone have questions for Gina before we move on? All right, we're running a few minutes behind, but I think we can make up for it in the last half of the meeting here. So, but definitely want to get into our subcommittee reports and hear about all the great work being done from each subcommittee. So we'll start out with Jessica Mantu reporting for the education subcommittee.
All right, thank you, Jesse. So our GCTE education subcommittee is meeting monthly. So we meet the first Tuesday of every month from 11 to 12. We have a really good group that participates. We are working on our GCTE goal work. So one of those is creating a transfer to definitive care PowerPoint. Kendra Holm is the lead for that group. We've completed a literature review and objectives, and we sent that outline to the other GCTE chairs for feedback before we work on the PowerPoint. There was lots of questions about duplicating work and kind of what the purpose of this work is. So I just wanted to remind everybody, we are absolutely welcome to feedback, but we're trying to create this transfer to definitive care and the acute kidney injury PowerPoints to help everybody. To kind of bring the literature together and make your job easier, give you another resource so you can share, you can present with your RTAC committees, for internal education, your outlying facilities. It's not just for trauma centers, and we're not approaching it as just education for trauma centers, because as we know, especially for the transfer to definitive care, a lot of our referring centers are not trauma centers, and they're the ones that really kind of need this extra support and this extra education. So that's kind of the purpose of this. We are a little off of our goal right now. So our goal was to have this work completed by the end of June. And we just haven't met that. So we're gonna look at those goals and create new ones. And hopefully get this stuff out to everybody by the end of the year, I think. But if you have any questions about transfer to definitive care, please don't hesitate to reach out to myself or Kendra. And once we create this PowerPoint, you are more than welcome to edit. We will try to make some slides that are you can edit yourself for specific stuff about your facility, but we're really just trying to make it evidence-based and applicable to all the centers that you can go to. And again, it's to make your job easier so you don't have to create this, and we're kind of moving the needle as this in the state as a whole. The acute kidney injury, very similar thing. The objectives have been created, the literature reviews completed. So, and we'll get feedback from the GCTE subcommittee chairs before we work on the PowerPoint from that as well. Our ask is, if you have specific literature that you want included in that transfer to definitive care or acute kidney injury work, please send those to myself and or Kendra. We communicate very well, so we can look at those, and we may already have included that work. Before I move on, any questions from anybody about those two? All right, so the state did have some extra money left over for education funding. So we were given about $11,000 to help fund educational offerings around the state. To date, we've spent about $9,500 of that. We spent $4,000 on an ATC, partially grant-funded ATCN course at Grady on June 11th. So we sent out a survey. We selected attendees from hospitals around the state via that survey, and we had quite a few. We planned to have 16 people attend, but we had a few last-minute cancellations due to COVID, unfortunately. So Erin was going to work on getting some of those people into her other courses. Big thanks to Erin for offering to host that GCT at Grady. It's just a great location that's kind of centralized. The second thing that we did, we spent $5,000 for a TNCC provider course at BB Putney. So that was completed on June 30th and July 1st, and they had 19 participants that attended that course. So what we did this year is, instead of the education subcommittee coordinating everything, we gave the money to those sites, and that site lead coordinated everything. We also spent $525 on the 2022 STN Trauma Electronic Library for statewide trauma center use. Our use agreement with STN is specific to trauma centers. So if you're not a trauma center, and it is great education, but unfortunately, that's what that ask was for. So if you're a trauma center and you want to use that electronic library for internal education, please email me. We sent out the author, I can't remember what the form is called, but I think it's like a MOU. So if you don't have that in your inbox from myself or from Jesse, please email me. I can send it to you, and I'm getting those out pretty quickly. And this is great education. So take me up on that offer, please.
Jessica, is that something that we should just send out? Like, I've already got a list of things that I need to send following this meeting. Is that something that we should just?
The MOU?
Yes. And then if anybody wants those slides, they would send it back to you.
Yeah.
Okay.
Let's do that.
That way I'm going to send you guys an abundance of information following this meeting, but at least it will all be in one spot. So yeah, do that.
Thank you.
Hey guys, it's Kendra. I just I was made aware this morning that there was a mistake on one of the slides that I that I did for that. And STN is going to be sending out the corrected slide. So if you've gotten them already, I guess, I don't know if Jessica will just forward the corrected slides out to everybody, but I had a brain moment and it just didn't work. So typed the wrong thing.
Well, thank you for that. Yeah, hopefully they will send those out to me. And how I'm sharing those is a huge shout out to Karen Hust for helping me stay organized. We have a Microsoft Teams account, and so we have all of those files in Microsoft Teams. So I can just upload the correct ones and I can send an email. So everybody that's already gotten access can just go back in and re-download. Thank you for that. All right, and then the last thing was we have $1,000 that was approved for a TNCC instructor course. To date, this money has not been spent. Our first selection to host this course, we had some communication challenges. And so the second selection, the person doesn't have a faculty member. So I'm trying to work with them to see if that's something that they are interested in still, and if we can get a TNCC faculty member down at their facility. And that's my update. Any questions? All right, great work by your group, and thanks for the report. And we will move right on to pediatrics. I do want to mention there's a couple of folks on the call who may have to get off a little bit early. So if they, Kelly Vaughn in particular, I may just say, let's do pediatrics and then let's do registry following peds, so that she can get off as soon as she needs to do so. All right, so Kelly Roker, if you would give us a pediatric subcommittee update.
Yep. Thanks, Jesse. We just had a meeting this past week, and we are continuing to work on pediatric readiness. We have a pretty good, solid list of equipment for caring for pediatric trauma patients. We pulled some PED-specific trauma guidelines, and Kendra kindly volunteered to skinny them down for more clarity on what pediatric patients need to be transferred timely, which will help with our initiative to decrease time to definitive care, hopefully. We also connected our injury prevention folks to see if they have anything to add to the pediatric readiness toolkits. We also shared SIPA data, so we're still trying to look at SIPA. Kendra shared her data with us, so we will be analyzing that. And CHOA decided to use trauma video review to study SIPA scores specifically, the recognition of shock and time to blood products. So that'll give us a little bit more clarity on how effective the SIPA score is, so that we can see if it's worth doing education around the state on SIPA, so that everybody can hopefully recognize shock a little bit sooner in the pediatric patient. That's about it.
Sorry, I was muted. Woman. Thanks for the update, Kelly. And does anyone have any questions for Kelly and the pediatrics subcommittee? All right, then we will move to the other Kelly Vaughn, for her registry subcommittee update.
Good morning, everyone. So the registrars met on July 28th and had a fairly long meeting. We went over the time to definitive care reports. The template, we created a template. We'd sent out screenshots, and different people have run those reports. We're getting that information back to Gina so that we can look at patterns or themes of whether it's missing data, what are the barriers to collecting that data. So that's in progress. The Office of EMS, Marie presented the annual report for the 2019 data. So we had a good look at what the data that all the registrars are submitting to the state, how that is used, and what all of our data collectively is showing. So that was nice. And then for the first time ever, we did a case study presentation. Gina, kudos to Gina. She did a great job with the same kind of process for those of you that were in St. Simons with the voting poll that we did there. We also did on the registrar meeting where a case was presented, questions were asked. We all answered the questions and then the right answers were reviewed. So that was really interesting. It was the first time we did it. It went really well. I think it was well received, so we'll be doing it more. And then
Thank you, Dr. Allen.
We also invited ESO. Debbie Bowman was on the call for just a little bit to talk about the web-based product that for those of us for the 3s and 4s that are gonna receive funding to go to the web-based registry. She talked about that process and next steps. Our next meeting is October 27th. And that's all I have.
All right, Kelly, thank you so much for that. And does anybody have questions for Kelly? All right, and then I know that John is not on, but I think, did we hear that Pam was going to provide the PI subcommittee update? Hey Pam, are you able to? I don't know if he did text or email Tracy and me, so he gave me a little bit of an update. But do you have an update, or do you want me to pull up?
That's the first I've heard that I was doing an update. So.
Oh, okay. I thought somebody said earlier you were, so I'm sorry about that to put you on the spot. Let me just find John's email that he sent me. I know Tracy Johns had to step off the call for just a minute to go to another meeting. But I will just read the email that he shared with me. He didn't say that. I don't know who said that earlier. All right. So John is doing a focus review this morning at his facility, so he couldn't be with us, but he did state that the next meeting is September 14th at 9 a.m. Zoom invite will go out. He said, as always, anyone interested can reach out to him. He's picked up several new committee members while at St. Simons. And he did say Tracy can provide some follow up on the AKI portion of their SMART goals. Their goal is to fine tune their efforts since we are starting to get an idea where and what they want to work on. So I think that committee has been really just kind of restructuring and getting these goals. The challenge was, or the ask was to get these initiatives developed. And so I think John and that group have their ideas down, and I think hopefully with his new members and everything that we'll have a good report next month on sort of where they're going. I don't know if anyone is on this call who was on John's last call. I was not able to be there. So if anyone has anything more to add, please feel free. Otherwise, we can just wait until our next meeting and hear an update.
Hey, Jess. That's a really good overview, and we had some discussion about some focused case reviews specifically around time to definitive care and looking at patients in between centers that have patients that have been transferred from one center to another to try to identify opportunities and around fluid resuscitation and AKI, et cetera. So I think we covered it.
Okay. All right. Thank you for that, Sarah. I appreciate that input as well. Anybody else want to add to that? I think that was good. I did hear that you guys were starting to work on the fluid resuscitation and impact on AKI and those type things.
Yeah. Hey, Jesse, it's Gina. From the AKI standpoint, now that the summer meeting's over, I can get with Rayma and I are going to work on the existing report that's in everybody's registry for AKI that we used years ago. And look at adding some things to it that we identified kind of need to be in there, and hopefully building some instructions to get out to everybody. I know Sarah confirmed that Grady still did have it, so we're hoping everybody still has it because it was actually pushed out by ESO back in 2016. But it needs a few additions and some edits to it. And then it should be a good standardized report folks can run to pull some initial information on their AKI patients.
All right, thanks for that update, Gina. I think we all know that's a top priority for us, so looking forward to the work. All right, Kelly Vaughn did have one additional thing to add to her report, so I'm going to go back to her real quick before going to Crystal Smith to finish this up for our subcommittee report. So Kelly, if you want to go ahead and take back over.
Okay, so one thing that did come out of the transfer reports, and it kind of ties into the data subcommittee that Dr. Dunn is heading up, is some centers have a problem finding or obtaining records from outside facilities. And so the process of requesting those records from outside facilities seems to be complex, and especially for those larger centers that have a lot of transfers in. And so in my previous experience in Tallahassee using Trauma One, we were able to create a letter in the registry, and the registrars could auto generate this letter, and then it could be emailed to the medical records of different hospitals. So I'm hearing that there may be the possibility in V5 to create letters. And I did not know on this group if there is anyone that knows how to do that, so that we could maybe screenshot it or show us how to do that, so we could send it out to the centers. Because from there, all you need to do is find the medical records departments in the other hospitals. A lot of times they'll have a records request email, and you can just email that to them, and that way it can go straight registrar to medical records. Does anyone, you can either put it in the chat or talk now, does anyone know how to do that?
And Kelly and I talked about this with Dr. Dunn, and I sort of volunteered up Linda from our facility, but because I know Linda has had some experience with those mail merge letters, with the follow-up letters, but I know the folks at CHOA do a lot of them as well. So I'm sure there's several on this call who could probably help with that. So yeah, if a few of you guys who do that often would reach out to Kelly and let her know that you have some experience with it, and maybe she could help then how the build, we could get a template built so it's not, something that you're having to adjust each time, but it would just be very similar process as those follow-up letters that we can generate through V5.
And I've put my email address in the chat, so just email me and then we can start that process.
All right, thanks for bringing that up again, Kelly. I appreciate that. I think that's actually really seems like a real potential. I guess my only question about that, and you may have told me down in St. Simon's, but how do the records get to then the requesting facilities medical records? How does it get into their actual record rather than just into the hands of the registrars?
So what we did in Tallahassee is, once the registrar got it, they worked with like TMH's medical records department. They had a shared folder, and they would upload it to the shared folder, and medical records would then retrieve it and slide it into the EMR.
Okay. It looks like we do have a question in the chat. Looks like Christy Griner is asking, what is our average transfer time for the state? I don't know that anyone will have this right off the bat, but Gina or Marie, if you guys want to take a stab. I think the problem, Christy, is that we really don't even know, because a lot of the time the data is not there, and that's part of this whole project is you're hearing a lot of people talk about time to definitive care, but we're kind of trying to attack it from a lot of different angles, because the key is that we need to get the data so that we actually know what our true time is, so we can set a benchmark and then we can start, the process we're trying to approve. But I'm totally be excited to hear Gina give a estimate.
Yeah, hey, it's Gina. And you're right. Part of our issue is the lack of the entire data set, especially for patients that are transferred in. So one of the things that we are trying to do is paint that entire picture from the EMS 1 scene to the time it gets to the definitive trauma center. And to paint that timeline, we only have the data somewhere around 25-30% of that data. So it's really not enough to be able to make some good generalizations about what it takes. But we have looked at time from hospital 1 to hospital 2. We typically will have those. That's much more, I want to say we're sitting about 70-75% of the time we have that information. And we're looking at an average somewhere between 4 to 6 hours, if I remember correctly, and if Marie is still on here, for that quarter that we really looked at. But unfortunately, until the state central site comes up, or and they accept more data, or the GQIP central site, we're kind of we don't have any other data to look at. The last we looked at was April through June of 2021 from that standpoint. So that's kind of a rough average from that. And yes, most of our transfers in, I want to say about 70%, again, come from non-designated centers and not from our 3s and 4s to our level 1s and 2 centers. So.
Right. And I think, again, and we're going to get to the speaking about the goals and things in just a few minutes, but I think that's why that work that the education group is doing is so important. If we can get that in the hands of those other non-trauma referring facilities, they'll better understand. But one thing I think we have discussed at previous meetings is that there has to be something in there for acuity of the patient, because right now we have 49 admissions holding an RED, and I'm sure you guys are all feeling that too. So if there's a kid who's out in our waiting room with, you know, an isolated ortho, not high acuity patient, they're going to be there for 4 or 5 hours just trying to get a bed. And so I think that was always our problem back years ago when we provided to Renee and Marie on the state quarterly reports. We had to talk about any patients that had a transfer time out of our facility greater than 120 minutes. Well, we failed miserably every time. And so we kind of set our benchmark more around our high acuity patients. So I think as we progress in this project, when we do set goals, I think we have to keep that in mind. We cannot expect that, you know, grandma with her isolated hip is going to get, you know, a rocket ship down to the level 1 trauma center. It's going to take some time for that workup, and as it should. I mean, and so I think all those pieces go into this very complex problem. But I think if we're really looking at getting the right patient to the right place in the right time, that's, you know, that is that high acuity patient who needs the services of a trauma center or a higher level trauma center, just to ensure they have the adequate resources. So I think as we talk this out, let's always just keep that in the forefront, that we can't generalize too much and expect every registry patient to be out in X time, or that maybe that's just my 2 cents.
Right, Jesse, this is Marie. When Gina and I and Dan Lynn and Renee and Liz have looked at the data that Dan Lynn gave us, we are looking at the high injury severity score patients and their outcome. We're also looking at those patients with a low injury severity score that's recorded and had a poor outcome. So we want to PI those type cases also to find out, you know, was the low injury severity score documented just due to a lack of documentation. So we'll be looking at it on both ends of the spectrum. And we do anticipate the referring facility data to improve as more and more centers are collecting that referring hospital data and sending it to us. I want to remind everybody in 2020, GCTE and the Office of EMS and Trauma agreed to not require the referring hospital data. So in 2021, we put it back on the data element list as being required. So it is probably taking people some time to get back into the routine and get ramped back up to go after those referring hospital records to abstract that data and put it in the registry. So again, we hope to see an improvement in the record completion rates for the referring hospital data. And definitely we'll be digging into those cases with high injury severity scores and low injury severity scores.
Yeah, thank you for that. And I appreciate Kendra's comment in the chat as well. I did catch that when you said it earlier, and I was really happy to hear that, because I think that gives those facilities, you know, something to kind of go on, that you're going to help them identify those, you know, those cases that do need to get out quicker and those that don't need rapid transfer. So again, I mean, this is just kind of exciting to me that the puzzle's seems to be coming together a little bit. So hopefully, although this is going to take a while, we will slowly kind of move the needle in this.
And another great, really eye opener is in the data that we've looked at, that Danilyn's prepared for us. She has broken it down so that we can see which regions, which EMS regions are transferring more patients and where those patients are going, you know, what EMS region they're going to, what their injury severity score groups are for the patient populations and the ages. So the data that we have, even though it's a very small group of patients from the April to June 2021 data set, is eye-opening, and it lays the groundwork for when we have all of the 2021 data. So I'm really excited and looking forward to seeing you know, the annual report for 2021 next year.
I agree. Well, thanks everyone for that. I think that was an important kind of sidebar conversation. So I think very good for us all to wrap our minds around it. Let's go ahead and move on to, oh, yes, I'm sorry.
I know we need to move on, but I think at the GTC meeting at St. Simon's, there was a lot of discussion about support in EMS to get patients moved. And similar to the college in the way that we look at timeliness of DISPO, meaning decision to transfer to ICU, decision to admit, et cetera. Has there been discussion about adding to the registry a decision to transfer out data element so that we know that time frame, and then we can calculate from that essentially the gap with transport issues?
Almost, I guess it may, I see what you're saying. I wonder if we could make it like the initial contact to the transfer center, because I guess that would really be the only, I mean, we wouldn't necessarily be able to get the actual time the doctor said, hey, this patient needs to go, but the time that he contacted the receiving facilities transfer center would potentially be.
Yeah, that would be a great time to use as well. Either one. We focused a lot on that here, kind of like you were talking about. You had to stratify the cases you were focusing on. We've focused in on those long-term that just kind of hang out and don't get a decision quickly, and we've made a lot of progress on getting decisions. But yeah, I think either time, that time would probably be more effective, the time that the call was made to the transfer center.
Sarah, in the patient registry, the Georgia patient registry, we have a couple of fields which we're trying to mirror in the V5, and it's the destination determination field, which is slightly different from what you're referring to. But in the Georgia patient registry on the ED acute care screen, there is a field if the patient's transferred and there's a delay. There are a couple of options, but this is not a field that's in the V5 yet.
Okay. And I know we're probably past, I think we're well past the window that we can add stuff for next year, but maybe that's something we can think about for next year.
Well, and hey, Sarah, it's Gina. To your point, one thing that we could utilize though for transfers out of the ED is that that order time. that's there. And I want to say, and Colleen, if you're on here, please correct me, but that was a lot of times what we used as that proxy when they would, say they contacted the transfer center or whatever to transfer that particular person for that. That's kind of your trigger. So we could talk maybe about, how do we utilize that field that's already there, that time to order field.
Yeah. I love that.
As that proxy.
Yeah.
Yeah, that's a great idea. I think if we could get Kelly and the registry group to kind of talk about that, maybe at their, I don't know, via email communication or at their next meeting and see what you all think. I would definitely want the registrar's input, but I agree that may be a very good use for that field on these patients who do transfer out. All right, guys, so I'm going to try to keep us back on track. We're a little bit behind, but I do think it's been a great conversation, so I don't want to, move over anything too quick. But let's just quickly get into Crystal Smith's report because they have been doing a ton of great work, and I want her to have the time to share with you guys.
All right, thank you, everybody. These are just some very, very basic slides. Those folks that attend our meetings are probably used to this format, just very basic. We do meet on the fourth Tuesday of the month, just to kind of let everybody know that we meet at 2 on the fourth Tuesday of the month. See if that's a big mouthful there. If you're not currently listed in one of these task forces but want to be, I've put the survey in the chat so that you're welcome to join us if there's any of these discussions that you really want to take part in. We would love to have you. So moving on to the recent Stop the Bleed Blitz, that was really the work of many people, but I just want to give a shout out to our Special Events and Projects Task Force because they really stepped up and helped get the word out and teach in these sessions, as many of you did. So thank you. Just a drum roll for the number of folks that we had come through these back to school blitz sessions. We actually had well over 2,600 people attend the webinars. So I think we're doing our job in terms of raising awareness of the trauma system and all of our partners. So just thank you. That could not have been done without you. Many times I said this was your blitz. Any of these sessions that you want to take part in, whether you want to help teach or just be a part of them as a spectator, you're welcome to join. A couple other things that have gone on, of course, over the summer, we had the Georgia Stay Safe campaign, and so those resources are still there. You can find them at www.georgiastaysafe.org. And you can download any of the resources. We've got all of our handouts, all of our social media content, activity books. Many of us have been able to take these to our pediatricians clinics, and our partners have been giving these out. So if this is something that interests you, just please visit that website and peruse. If you have any questions, give me a call. But thank you for everybody that participated in the Georgia Stay Safe campaign and that are still participating. So September is a very busy month. Our Violence and Self-Injury Prevention Task Force is actually going to host a suicide prevention lunch and learn session that's going to be September 29th. We actually have Alicia Cook. She is a youth suicide prevention specialist with the Georgia Department of Behavioral Health and Developmental Disabilities. She's going to come in with some members of her team. She is a member of our subcommittee as well, and just tell us a little bit more about the work that they do, and tell us a little bit more about the new 988 hotline and some of the resources that are available in the state in regards to suicide prevention. So hope you'll join us for that. Falls Prevention Month is also in September. So our Falls Prevention Task Force is still very busy with bingo size. Everybody's having a great time with that. We're teaching it in a variety of, or delivering it in a variety of different formats. I know several of us are going to partner together to perhaps start a new one in October that's going to be targeted more towards smaller groups. We've had some really large groups, but smaller groups in terms of like church groups, Bible study groups, and individuals that are playing at home. So if you've not had a chance to be a part of that and you would like to be, we definitely would ask that you would consider joining us. Georgia's Falls Free Friday webinars are actually run by iPrice and our Department of Human Services and DPH partners. They're going to do a webinar at 10 a.m. every Friday in September, and then one Friday in October. It's going to be over a variety of different falls prevention topics. But our Georgia Trauma System Day, or in partnership with the Middle Georgia Regional Commission, we'll be doing a Falls Free Friday bingo size demonstration. Actually, Sharon Grayson is going to represent us as the trauma community in doing that, and joining Nicole Gaither to deliver that particular webinar. And that's going to be at 10 a.m. on Friday, September the 16th. Be on the lookout. We're updating our social media guide, so you'll see some new content about Georgia Health Matters, the area agencies on aging, and we're going to add some pediatric falls prevention content to our social media guide, as well as some other resources. So be on the lookout for that. And then finally, for our traffic injury prevention task force, September is a big month for them as well, with it being Child Passenger Safety Week. Many of our committee members, particularly those with DPH, Safe Kids, and our children's hospitals, are going to be involved with CPS events, and many of us will go out and assist with those. But our in-house content expert, being Renee McCabe, is actually going to do a trauma after hours webinar. This is more for clinical folks, more for, I would say, your frontline folks in your ERs, perhaps even your triage folks, your EMS folks. This discussion is actually about pediatric restraints and the lack thereof, and how they relate to the various injuries that we see. This was something that was born out of a regional PI initiative. And Renee just did such a great job with this in the spring of last year. And so we asked her to come back and deliver this education again for us as a trauma after hours presentation. So for those of you that don't know Renee, she's with the trauma department at Augusta University. Also in October, we're going to have we're going to revisit our teen driving safety webinar. So the road ahead will be Thursday evening, October 20th from 6 to 7 p.m. Again, we have teens join from all over the state. Many of our own teens have participated in these webinars. So we're going to have a trauma survivor from the Savannah area that's going to join us. Again, I think Sharon Grayson and perhaps Maddie Parks will help us moderate this session. We're going to have a group of teens come in with the Teens in the Driver's Seat program to discuss their efforts, and also a presenter from Mothers Against Drunk Driving, or MAD, is actually going to come in. So be on the lookout for a lot of announcements coming up. Share it with the appropriate folks in your community. And just going back to the Stop the Bleed Blitz, again, thank you, thank you, thank you. That is definitely powered by you. I don't have the reach to reach out to 2,600 people. That is you and your contacts at work. So thank you for that. And we are going to have kind of a follow-up meeting if anybody wants to participate on this coming Tuesday following the RTAC coordinators meeting. So it'll be at 2:30 p.m. That meeting is about connecting the dots. So we've done the webinars, how do we get the skills training delivered to these people? And so if you would like to participate and help us make sure that the skills training gets done, we know that more than 60% of these participants, this particular blitz, have never had Stop the Bleed before. So it's well over, 1,500 people there that we really need to make sure they get the skill set as well. So I know that was a long report. I do apologize, but just a lot going on with our different task forces.
Yes, lots of work. So we do appreciate you giving that report and always being so appreciative of the collaboration of your team. You got a great group of folks with you, so make us look good as a state, I think. All right, any questions for Crystal? All right, so we are just a little bit behind, but that's okay because I had built some time in for like roundtable and stuff like that. We can obviously shave that off if needed, but I did want to just briefly talk about the GCTE goals / vision. If Gabby, if you don't mind to pull that goal sheet back up whenever you get a chance. As you guys have heard, each subcommittee chair has sort of presented their updates, especially related to their goals. And for those who are new to the call, the probably about a year ago, I think we kind of decided to choose a few focus areas, or what we call them initiatives for GCTE, that would really align us with the work that's going on across the Georgia trauma system as a whole. So often we're all being pulled in different directions and working on different things, but we really wanted this subcommittee of the Georgia Trauma Commission to kind of better align our work and not, I don't want to say simplify, but just make it a little more intentional what we're working on, rather than grabbing at every little problem that comes across our desk. And so I really am proud that we've done a good job of setting up some great initiatives. And just to remind everybody, the initiatives were: first, to decrease time to definitive care; second, decrease incidence of acute kidney injury; and third, increase trauma awareness. And the ask was that each subcommittee address 1 to 3 of those. And you can see here on the slide that that's exactly what you guys did. And although some of the groups are still kind of working to formalize these goals a little more, I think we are really at a good point. And we knew that this would not be a short-term thing. These were designed to be 2 to 4 year type projects before we actually really see much result from them. So I really appreciate the updates today. And I, hearing, and Jessica talked about, reaching out to the other subcommittee chairs to ensure that we weren't doing duplicate work and everything. And today it was really nice to kind of hear everybody reporting on the same thing, but it was very different what part of that project that they were reporting on. And I think that's exactly what we designed this for. And so I hope that you guys are kind of seeing it come together. And no, I'll keep picking on Jessica because she's sitting next to me, but I don't expect that the education subcommittee is going to actually decrease the incidence of acute kidney injury by themselves by the work they're doing. But what the vision was that, through their education, through their lit reviews and the creation of that PowerPoint that's going to go out to so many people, will start gaining a better understanding of what AKI is and what we can do to prevent AKI. And then, long term, hopefully we really will see a decrease in AKI. So again, that's sort of just the generalized kind of vision, I guess Tracy and I were going with when we brought this before you guys a while back. So I just we want to keep this on the agenda as old business, just to touch base and just to ask if anybody has any comments, questions, concerns. I mean, do you guys feel like this is working well? No comments, questions, concerns? I've talked with several of you individually, and it does seem that you feel that this is a little, aligns with the work you're already doing, and it is a little bit more focused rather than kind of trying to figure out, okay, what do we work on next? So the feedback I've received just from a handful it's been pretty positive, but I'm certainly open to feedback, recommendations, and anything of that sort. And I know Tracy will be too as she resumes the chair role, but I just think it's been great work, and I'm looking forward to, kind of seeing these things.
No, sir. No, sir.
If you don't mind, mute your lines if you're not speaking, but does anybody have anything to add to the GCT goals and vision? Everybody have a pretty good understanding of where we're going there.
Jesse, I'd just like to second what you've said. I feel like, from what I've heard from people too, that it's kind of helped us focus a little bit better on what we want to do. And while we have goals, sometimes we can get off on the timing, or maybe we veer a little bit, but that's okay. Goals are meant to just kind of help direct us where we need to go. We don't need to abandon them, but we can regroup. So something that, you know, I want to do and would love for you to participate with, and I think we've talked about this, is kind of meeting with the chair of each of these groups and kind of refining and seeing, you know, going into 23, where do you kind of see us going, or what do you want to work on? And I think that'll just kind of keep the momentum going. And like you said, I don't think it's going to be any one effort that changes or moves that needle, but it's all of us learning together and just exploring these two big areas about going to definitive care and decreasing AKI incidents.
Yeah, I agree. And nothing really speaks to it more than Crystal's report she just gave about, you know, obviously she can't go out and impact all these people alone, but because she has a collaboration, and that's what this group really is, we can reach so much further rather than just me trying to decrease the incidence of AKI up here at Northeast Georgia Medical Center. So I think that we're seeing that all of us coming together is a strong force. And so I appreciate everybody's efforts and keep up the good work. And yeah, Tracy, I agree. We can talk with people going into 23 and just sort of do a touch base and see if we need to alter anything. But I do feel like we did create some pretty good bones here. So, all right. So moving on, we do have a couple of new business items, and this one will be pretty quick. Karen Huss brought this up to me, and she's going to just talk very briefly about a registry partners and inter-rater reliability pilot that they're working on, and maybe see if anybody else is interested.
Thanks, Jesse. We all know that IR is really that key to ensuring the data validity in the registry. So, you know, I am relatively new. I have a year in the TPM role, and I'm definitely not an expert in the trauma registrar role. So, you know, as a level 3, we don't have other registrars. You know, for 3 and 4s, we're kind of in a unique situation where we don't have another registrar in the office to IR our charts. So in trying to identify an option, I reached out to some folks at Registry Partners for assistance with validation of the data and identification of specific areas of trauma registry education that would assist in improving our quality. So we agreed to a selection of 3 months worth of charts, 10 cases each month. They focused on complex patients with higher ISS scores and a mix of admitted and transferred patients. And following each set of 10 cases, Registry Partners had a phone call with us. It was virtual. You know, they shared several PowerPoint slides where they shared things like, you know, a tremendous breakdown of the actual data that they had collected, the average IRR scores, summaries of findings, breakdowns of discrepancies into categories, into missing versus disagreement. They did a breakdown of the injury diagnosis disagreements by body region and AIS versus ICD-10 injury diagnosis disagreements. This information was provided to us before the call, so our registrar could go in and look at it and identify if she had any questions, concerns, disagreements of her own to send back to them. So we all went over this information together, and then we also received recommendations for areas that we could concentrate on to improve our performance moving forward. There were specific resources provided, and we have the results of the 3 months of IRR. We saw a 55% decrease in missing data and disagreements from the initial to the third set. We saw a 54% decrease in ICD-10 and 43% decrease in AIS disagreements from the initial to the third set, and then also a 50% decrease in injury disagreement from initial to the third set. So having someone that was professional and really knew their the information that needed to be in the registry and how to collect it and where to find it and all that was huge for me. It was a huge relief for me to be able to pass this off to someone that could do this professionally and then share the results in such a useful format for us. So I am going to put my contact info in the chat just in case anybody has an interest in exploring this opportunity for themselves, for their particularly for the level 3s and 4s, but they of course would be willing to work with the 1s and 2s as well. So thank you.
Thank you, Karen. Yeah, we just thought she had such a great experience, and I'm sure that the struggles are similar across the center. So thanks for that, Karen. And please do put your info in the chat. And if anyone has questions, reach directly out to Karen, and she can help you out. All right, so we're going to move to our next agenda item, GCTE Executive Committee. So I just wanted to kind of share this here with you guys so you would know what's going on. But all of the subcommittee chairs and myself and Tracy, and then I think Liz and Gina were actually on as well. But we decided to revamp the GCTE Executive Committee. I guess this used to be a thing years ago, and it was a good way for the subcommittee chairs to kind of cross, ensure that they weren't doing a lot of duplicate work, and sort of just to keep those leaders of the subcommittees all on the same page so that we could better go back and kind of lead our groups. And so we revamped that group, started meeting again just before we went to St. Simon's. And it was obviously our first time, but we did talk a little about the PVP information that Katie shared earlier. We did talk a little bit about some of the goals, but I think it is a good thing. And for those of you who eventually will be rotating into some of these subcommittee chair roles, I think this is, just another forum for us to network and collaborate with our colleagues. And so I just wanted to keep you guys aware. There's nothing really to report there unless Tracy has something that she would like to add, but I just thought that was important to tell you guys. We're going to do that, and we're going to try to meet at least quarterly, but potentially more often than that.
Jesse, I'd just like to add that we did discuss trying to have at different meeting venues or somehow to give an avenue for the registrars to meet and be more collaborative. And you kind of touched on that when we were talking about, and Gina did too, talking about Chateau Alon and the other state meetings. So that was brought up to several of us, and we've heard your cries, and we want to very much support that, because just as Karen talked about, data is important. And, our registrars are the basis and the strength of our programs. Because if we don't have accurate data to work on, then everybody else in the program can't do what they need to do. So we do want to be very supportive of that. And so I just wanted to mention it.
Yeah, thanks for that, Tracy. And I think that also kind of as a reminder, when you guys do give feedback for the FY24 PVP things, keep that in mind. And what we, obviously it would be great if every single quarter we could go back to the old days where we rotated trauma centers across the state. We all went, we all, grab lunch after or whatnot, but the world has changed. And I think we have to be realistic about that. When we do have the convenience of a virtual call, that's great, and it avoids the travel expenses for your center and those type things. But I don't think any one of us would say that virtual is enough. I think we have to have some FaceTime, and not just for the registrars, not just for the leaders, but for all of our program staff. I think it's important. And like I always say to our team here, it connects you with the purpose of what you're doing. And I think we're all doing great work in our own centers, but I think we always need to remind ourselves that we are impacting trauma care in our state. So I think that FaceTime is extremely important. And so just know that we are trying to work that out while also being reasonable and knowing what we are going to be able to ask of each facility's kind of administration. I guess, it does cost a lot to send folks to different things. So So just keep that in mind and know that we're all trying to get back to some sort of, maybe it's twice a year that we're able to do FaceTime. And that, that is actually that's decent. We used to do it 4 times, but if it's twice right now in this day, I think that's a fair compromise. So thanks for that, adding that in, Tracy. But I think that group's going to be very good to discuss things like this and really to bring things to light. And so please, for all of you guys who do have some concerns, maybe, may not have anything to do with in-person meetings, but if you have some concerns about, where we're headed with GCTE or whatnot, make sure that we as the subcommittee chairs or myself or Tracy are aware, and we can kind of hash it out at this place as well. So then let's just move right into the upcoming GCTE vice chair election. We are planning to, I guess, nominate and elect a vice chair during the November meeting. And then during the January meeting, Tracy will take over as chair and that new person will take over as vice chair. So I've sent this out in the email to the group just to remind you guys. The chair has to be by our bylaws. It does need to be a trauma program manager or director from a level 1, 2, or 3 trauma center. So if anyone's interested in becoming the vice chair, which will be a 2-year term, then you'll take over as chair. Please reach out to myself or Tracy. We haven't had a ton of interest, but we have some 1 or 2 real good folks who would do a great job. But I definitely, this is, again, this is our committee. And so we want to make sure that, everybody kind of has a voice in that. But it is an extra responsibility, and, we have to all balance where we are in our own careers as well. A couple of years back, I wasn't able to do this because of some, I had a baby and lost my boss and all this stuff, but the timing came right and I was able to do it. But so you may be in a spot where it's not a good time now, but later it might be. So hopefully we'll have a couple of people who are really interested and we'll just keep this train moving. So I know Tracy's going to do a great job when she takes over as the chair, and I will I'm going to stick around and be your past chair, and then Karen Hill will finally be off the hook. So anyway, does anyone have any questions about that? All right, so before we do a roundtable, let's just kind of talk about the next meeting, because I think we've nailed that down. The next meeting is going to be on November the 16th in Macon somewhere at Tracy's, at Navicent. Tracy's working on a room. I think she's got a room secured for us, but we'll definitely share those details about the exact location. Time's going to be from 2 p.m. to 4 p.m. There will be an in-person or a virtual option. One of the things is the Trauma Commission meets the next morning, and that whole day is going to be sort of a rural focus. And I know the RTAC coordinators are also meeting in Macon at that same time. And so I think if we can get some folks down there in person, it might be a good opportunity for us to try another kind of networking thing like we did last year, where a few of us went out to dinner in Macon or in Forsyth. So we'll be in Macon this time. I think sounds like the commission meeting is going to be held at the Marriott there in Macon. And so anyone who's planning to go for GCTE and stay the night, if you can try to get a room there at the Marriott or somewhere close, that's the best bet, because the commission meeting would be the following day. And I always get questions about this, who's required to go to the commission meetings. No one's required to go, but I do think it's important for us, especially your trauma program managers and directors, to be aware of what's going on with the Trauma Commission. I report there on behalf of our subcommittee, but it's definitely a place where I think the commission members and the other attendees are, it's good to show the strength of our group. And so some presence is very helpful. So please try to attend in person if you can on the 16th. And you don't have to stay the night and do the Trauma Commission meeting. If it's relevant to you, then absolutely try to do that. But if you can just come down, Macon's a good central spot. So a lot of people, that's within, it's a day's drive, go down in the morning and turn around, you can do that. So hopefully we'll see a good crowd. Tracy, do you have anything to add about that meeting?
No, the meeting will be at a hospital. There is free parking as long as it's 2 hours or less. So that kind of puts a damper on Jesse or myself as far as how much we talk. But we welcome you to come, and then it'll also be the virtual aspect also.
I think that's great. Is there anyone on this call who knows that they will be here, who's kind of like a cruise director, loves to organize things, who would like to take on organizing an outing for our group that night? Nothing formal, but last time I think Crystal did most of the work and got us a reservation. I'm happy to take it on if no one else volunteers, but if anyone wants, just kind of think on that, shoot me an email in the next couple of days if you're interested in doing that. It would be helpful, and I think engaging for others to do that sort of activity as well. All right, so moving on. I have a spot here. We have 4 minutes left, so we'll combine roundtable issues and concerns. I'll just start by saying thanks to everybody. I think we've already kind of had somewhat of a roundtable about several of these topics, but if anyone has something that's going on at their facility that they want to bring up, that you think that might benefit, or if it's a struggle you're having that you think we might can help with, let's just take a couple minutes to do that. Just unmute yourself and pipe in. I know everyone's trying to speak at once. I'm just kidding. Well, if you guys don't have anything, I don't want to, force awkward conversation or pauses. So it is lunchtime. I'm sure everybody's ready to go get food. So I will turn it over to Tracy to wrap us up.
Okay, well, if there's no other business or anything, anybody has anything else to say, we'll adjourn our meeting at 11:57. Thank you for joining us, and we look forward to you joining us November 16th from 2 to 4 p.m. Thanks a lot.
Bye.
Bye, guys.